اوكي، تفضلي دكتورة.
Okay, تمام. I will talk about prosthetic complications and maintenance, the current topics and trends. Okay. First, I will talk about complications and barriers related to removable prosthetics, and then we will proceed to other categories. Okay. First, complication related to removable partial dentures. Um, as we know that the patient's adaptation or acceptance to RBT treatment is not as always as we expect. Actually, in some studies, they reported that 30 to 50% of the patients never or only occasionally use their RBD. And one may think that this is only attributed to the patient's lack of adaptation or psychological factors related to the patients. And this is might be true, but mainly, or there are some reasons that play a major role in this problem, like the poor planning from the dentist part and the poor execution of the design or the treatment from the technician part. As you will see here, that there are failures that are related to the carelessness or the lack of professional experience of the dentist that can cause failures of the RPD, and as a result, the patient acceptance will not be as great as we expect. Okay. So first source of failure is the absence of diagnosis and planning. And some dentists make the technician do the planning while knowing that those or these technicians are not equipped with the appropriate knowledge or the sufficient knowledge to design the RBD. So it's only the dentist's responsibility to make the appropriate design. Also, the absence of cavity preparation is one of the most common sources of failures in RBD. Also, the failure to adapt the metal superstructure of the RBD in the absence of functional casting of the distal extension, and this can be due to the improper or insufficient secondary impression. Also, the absence of care and instructions during the placement of the RBD in the absence of follow-up visits or appointments. And I have read somewhere or some article that only 10% of the RBD patients are recalled for periodontal checkup or for oral hygiene maintenance. This can be a source of complications, and thus the patients will not be comfortable wearing the denture. Okay, now I will talk about the most common complications related to removable prostheses and how to manage each scenario. Okay, first I will talk about complete dentures. The most common failure or most common complication related to complete denture is the fracture, and the most common site is the midline fracture of the upper or maxillary denture. The causes of fractures can be related to denture factors or patient factors. For the denture factors, it can be attributed to poor fit of the denture. This is one of the most common reasons, and itself can be attributed to many factors like alveolar resorption, which will cause the denture to or the stress to be unevenly distributed over the denture base, causing a fulcrum, inadequate or excessive relief, failure to relieve bony prominence, sectori, and thin mucosa. Also, inaccurate impressions or cast can induce stresses in the denture base during mastication, and it will cause uneven support and causing the denture to act like a fulcrum And the inclusions like porosity and plaster dust can also contribute to stress concentration and growth of crack and eventually leading to fracture of the denture. The second reason is incorrect tooth position, like sitting the teeth. The most commonly improperly set teeth are the upper teeth. They are usually or sometimes set outside the ridge, which will lead to midline fracture of the upper denture because the force of mastication is applied outside the axis of the ridge, making a fulcrum point. Um, Now the problem can be avoided by widening or extending the denture base more uh, to the contralateral side to involve more areas, so we can shift the fulcrum and distribute the loads more evenly. And also we can set or we should set the teeth in balanced occlusion um, in the use of something to strengthen the denture base like metal in cases where it's indicated. Okay. For the patient's factor, the most common factor is or source of fracture is the accidents. Accidentally dropping the denture by the patient can cause fracture due to can cause impact fracture, as you will see in the next slide that we have impact fracture and fatigue uh, fracture. Okay, anatomical factors, problems like high labial prenup, so we need more relief. So this deep labial notch can cause concentration in the midline area and fracture of the upper denture. Also, the patients with high secretory forces or powerful muscles of mastication can be at risk of midline fracture of the denture. And also the patients who have or exhibit signs of bruxism. Okay, the fracture can be, as we said, impact fracture or fatigue fracture. Impact fracture is when the denture is accidentally dropped on a hard surface, and this fracture depends on the point of impact in the direction of force applied on the area, which yani, it's different in each case. Okay, for the fatigue fracture, it results from repeated stresses on the denture, repeated flexing of the denture by forces too small to cause direct fracture. This fatigue is concentrated in the surface of the denture. The crack will propagate or continue to grow until the denture eventually fractures after years of use. Okay, whatever the cause, it must be identified before starting the treatment because otherwise the denture is likely to fracture again within a short period of time after we repair it. Okay, now how to reduce the incidence of fracture? As we said, the misfit or the lack of fit and the instability of the denture are the causes. So we maximize the denture stability and the denture fit. We provide the denture with completely balanced occlusion to reduce as we said, the fulcrum and the wedging effect. We also we should try to balance between the thin thickness that is comfortable for the patient and the adequate thickness that resists the fracture of the denture. Also, we the deep trainer attachment should be made shallow to reduce, as we said, the risk of midline fracture. Also, during flasking and denture processing, slow cooling can also minimize the internal stresses and reduce the risk of fracture. As we said, we should avoid deep notches. It should be made shallow as much as we can to avoid the stresses over the denture base. Good processing techniques, which includes we try to minimize the residual stresses within the denture and avoid the surface defects and inclusions. We We should also make sure that we made relief for the areas that need to be relieved. Um, and as we said, over the non-compressive tissues in the center of the heart palate. Okay, and last, we should increase the base thickness, as we said, as much as we can, because it will increase the fracture resistance of the shallow palatal vault cases. These patients, by the way, are at risk with shallow palate, are at risk of denture fracture. Okay, now for the denture repair, there are the three types of materials that we can use. We can use the cold cure resin material. It's the most commonly used. But this material lacks the strength of the heat cure resin cements and is associated with the repeated fractures. We can also use the heat curing resin materials. It provides the highest fracture resistance and fractural strength, but it's time consuming, it's higher cost, and it requires dental laboratory work or support. Okay, and then last is light curing resin materials. These can be used, but the use of these materials is not established yet, and there is insufficient long-term data to support their use. There are also many limitations of this material, such as increased water absorption, poor adhesion to plastic teeth, increased brittleness. So it has reduced impact resistance. Okay, now let's talk briefly about the repair, the midline fracture repair. First, we bring the two broken parts and then we try to approximate them, and then we glue them together with the sticky wax. We can also support them with two sticks, as we can see here in the figure. Then we block out the undercut and the surface with wax, and then we pour the stone into the fitting surface and allow the stone to set, and then we remove the denture from the cast, clean the denture, and to clean the denture from the sticky wax. And then we reduce the fracture lines, as we can see here in the figures or in the pictures, to maximize the surface area for bonding. We can also strengthen the joint with adding dovetails, as we can see here. And then we paint the cast with separating medium, and then we start applying the cold curing resin cement to the modified area that we made the bevel in the dovetails. It's overfilled with the material, and then after it's cured, we relieve the mid-palatal area because it will be bulky because we added the material, and then we finish the denture. Okay, now if we have a fractured acrylic teeth, the procedure is simple and straightforward. We remove the remaining fragment of the acrylic tooth carefully, as we try to maintain the buccal and labial contour as much as we can. And then we choose the new teeth to be placed, and then they are glued or they are connected to the denture with cold cure acrylic resin. Okay, for fractured flanges, we first apply or the area of the fractured flange is filled or covered with compound, and then the denture is poured with stone, and then we have the cast, and then this area of the compound is replaced with a cold cure with acrylic resin. It's also a simple and straightforward procedure. Okay, now I will talk about failures related to removable partial denture. The most common failure is the fracture of the clasp, and there are many reasons for for this incidence. as it can result from repeated fracture into and out to severe undercut. When we have severe undercut and the repeated fracture around it will cause the clasp to fracture over time. Uh, if the tooth is healthy and the periodontal support is good for this tooth. The tooth is mobile or the periodontal support is not healthy, and then the weak part here is the tooth. So the tooth will be loosened with time and eventually will be lost because of the persistent strain on the tooth. So the victim is always the weak part. Okay, the other reason for fracture of the clasp is structural failure of the clasp arm itself due to problems in processing, careless finishing and polishing, and also uneven thickness. It will break at its weakest point. So to avoid this, we must provide uniform thickness at the connection of the non-retentive clasp arm in the connector and the minor connector, and we must make the retentive part as tapered as possible with even thickness. Okay, the last reason is careless handling by the patient. When the patients are not educated um, on how to use the prosthesis properly, how to remove it, and how to insert it. And sometimes it breaks because, as we said, because of the impact fracture when the patient dropped the RBD. Um, is subjected to excessive abuse by the patient, as we said, and this is the most common cause of failure of the cast clasp or. Okay, now let's talk about the management. There are two techniques or approaches to manage this scenario or this problem. The first is by using a root wire, and this one is easy and straightforward. First, we take pickup impression with alginate impression, and then the impression is poured, and then we have the cast. We highlight the height of the height of contour, as you can see here in the pictures, the canine area, and then we place the root wire. We adapt the root wire. In the lingual surface, we make a space for the root wire in the platter surface of the adjacent tooth, as you can see here, to make space for the material. And we make a curvature here on the root wire itself to secure it more in the material so it doesn't break or doesn't come out of the material. Okay, and then we apply the cold cure or the polymerized resin and finish and polish the final prosthesis. The other approach is the repair with cast clasp. In this technique, now we have the cast and we make a pattern for the replacement clasp. It's fabricated from either wax or autopolymerizing acrylic resin, as we can see here with the brush over the cast. And we made here relief of the undercut with wax, and then we place the resin to make pattern for the clasp. And then after we finished, we have the resin pattern. After the material is hardened, the clasp is removed, refined, and polished, and then it's cast. After we have the final clasp, we return it to its position to make sure it fits in the appropriate position, and then we attach it to the major connector with electric soldering, and then it's polished. It's ready to be inserted in the patient's mouth.
عفاف ممكن سؤال.
اتفضل.
يعني السترينث للريبير لنوع الريبير هيك، يعني كان مكتوب إشي عنه ولا لا؟
هلا هو the root
يعني
wire is considered as temporary in the cast clasp is
يس.
supposed to be a better option.
better than الروت وير كلاس.
Yes, yes. But survival, يعني I haven't read something
Yes,
about
on
survival.
the long term, I mean.
As survival, I haven't read something about it.
Okay. مسلم
It's
مسلم.
the like the gold standard option or technique for the repair. It's still better than the root wire.
يس
As
أنا صار
the
معي حالة فراكتشر الكلاس. صراحة إنه يعني اللي كنت يعني قرأت أكثر من مرة، إنه سمعت إنه هيك بيكون أضعف، يعني إنه من
because of
هذا
the sound.
يس، يعني as a long term، لأنه كمان السولدرينج اللي راح يصير إنه مش موجود عادة، وبيكون فيه مشاكل يعني.
Yes, yes, it's the weakest point. Yes, it's,
يس.
shoulder bone.
أوكي أوكي، يسلم يسلم.
Okay, now we will talk about complications and repair of fixed restorations. First, we will talk about the survival. This is a systematic review published in 2017. It included clinical studies on inlays, onlays, and crowns, all materials, PFM or ceramic, and even gold inlays and onlays were included. The mean survival rate of inlays was 90%, while onlays and crowns were 93 and 95% respectively. As يعني it's logical that inlays always have lower rate than onlays and crowns. Okay, for the complications, the most common biological complication was caries, followed by root and tooth fracture incidents and endodontic incidents. For the technical complications, the most common one is the ceramic fracture, followed by loss of retention and porcelain chipping. Okay, as we talked about okay, now we will talk about these, the most common complications and how to manage each scenario. Okay, for the chipping of the porcelain, it can be chipped over a zirconia framework or PFM framework, and we have two options. First option that we take out the restoration and send it to the lab to re-veneer the restoration or to make a new restoration. And this option is not, let's say, it's not practical for many reasons. First, it's very difficult to remove permanently cemented crowns without damaging or distorting the restoration or the tooth. And the second is that it needs considerable effort, discomfort to the patient, time and cost. It needs much time and cost than other options. The second option would be repairing the restorations intraorally. This solution is interim, but it's reasonable. It's any makes sense more than the first option. The easiest way is when the fracture is small or when it's on the posterior area, like we can see here in the picture. This one is a little bit large. We can just do simple polishing just to prevent the plaque accumulation over the rough surface. So we just do simple polishing. Otherwise, we have in other cases when the chipping is in the anterior region or when it's large and the metal framework is showing, we have three options. First, we replace the missing piece of porcelain with composite resin or reapply if we have the broken piece, we can take it and do surface treatment and then re-cement it over the old restoration. Or we can prepare the restoration for a new veneer and adhesively bond the veneer over the old restoration. Okay, I have 10 minutes. Okay, regardless of which option I will use, I always need surface treatment, and it depends on the material, the substrate material, and the new material, the new restoration. Okay, so there are a few ways to make surface treatment, either micromechanical retention, chemical bond, or bifunctional phosphate monomers like 10 MDBs. Okay, here, as we can see, each material have different surface treatment according to the material composition. For the all ceramic, we can use hydrofluoric acid as a micromechanical retention in silane, and then the conventional resin cements. And here, the conventional in a modified, by this they mean if there is MDP incorporated in the cement or not. If there is MDP, it's called they call it modified resin cement. Okay, so for the zirconia or alumina-based restorations, if we have delamination, which is adhesive failure, we can use the Cojet. This is like a repair, two bottles for repair from 3M. It's like applying a ceramic layer over the metal or the zirconia. It enhances the bond of the restoration. So we can use it for metal restorations and zirconia and alumina-based restorations. Okay, and then we can use MDB containing primers and conventional or modified resin cements. Now, if the chipping that occurs in the zirconia-based or alumina-based restorations is a cohesive fracture, and the zirconia is not exposed, we do surface treatment for porcelain only, which is hydrofluoric acid, or both if the zirconia is exposed, and then we do silane coupling agent and conventional resin cements. Okay, and same applies for the BFM restorations. Okay, this is a case report. I don't know if I have time. I have 7 minutes. A case report of
can we leave this case reports for the next session, inshallah ta'ala?
Okay.
Okay, and we will end here for part 1 and see you later in part 2. Thank you very much.